So we'll talk a little bit about some of the other recommendations. If you look in, and this comes right out of the article from JAMA about non-statins. That's why I said when we talked about the cholesterol, it was all based on statins. And you'll start to see the colors, actually what I want to show. Most of these are yellow or red, which means either use with caution or don't use. There's not a lot of good recommendations, and the reds are actually things like niacin probably should not be used, and we used it in the past. And then look at some of the other medications that are available. You start to see the reds and the yellows. So I'm just going to point out that there are some other things there, like the fatty acids, the omega-3s. They do carry some recommendation. Used more to treat hypertriglyceridemia than just cholesterol. And you see that, again, not a great robust number needed to treat, somewhere between 350 and 400 for a year to get one additional benefit. And if it is high risk, it's a little bit better. The American Heart Association still recommends 2 fish servings a week. For those without coronary artery disease and those that are documented, they actually recommend EPA plus the DHA. And again, you need a pretty good dose, somewhere between 2 to 4 grams of the EPA plus DHA daily. Problem is that some of the stuff's expensive, and it does give you sometimes the fishy aftertaste. If you're worried about just that and then taking on like fish that are what we call the oily fish, you have to worry about some of the environmental toxins. I always joke I live in a Saginaw Bay watershed, which is where there's been a lot of dioxins in the past. And so our recommendation is men are allowed to eat 1 fish a week. Women and pregnant women and children should not eat any. Go figure. Other medications that we've done in the past, things like the fibric acids, again, more for triglycerides that have complications, things like hepatitis, cholelithiasis, myositis, in combination with the statins, increases that risk of getting the muscle injuries. And then the question about what about Zetia? In addition to the statins, it was an add-on. It doesn't really change your HDL, may lower your LDL. It really hasn't been all that well studied, and most of the recommendations for cholesterol say statins, statins, and statins. Herbal therapies, things like red rice, green tea, increased soluble fiber, Mediterranean diet. Again, people have tried them. If it works for the patient, maybe, but it's, again, doesn't carry a great strong recommendation. All right. I know Bob had talked about, blowing up EKGs during the board, about the board's lecture. And we're going to talk about a specific arrhythmia only because it's the most common, but just a comment about arrhythmias on the board exams. If you know your ACLS protocols and the dysrhythmias, that's all you need to know. They're not going to ask you about the left anterior fascicular block with a biventricular block. That's cardiology boards. They're going to ask you straightforward stuff, A-fib, VTAC, V-fib, Mobitz 1, Mobitz 2. They're the things that are the good food for father. And again, I agree with Bob. Read the question, answer it, then look at the EKG. So if it says, this patient presents with an irregular rate and rhythm at a rate of 170, what is it? Don't look at the EKG. It's A-fib. Right? So again, the A-fib here, the most common of our sustained arrhythmias, and we now know without treatment you get an increased mortality and morbidity, both thromboembolic and also, again, tachycardia-mediated congestive heart failure. It's a lack of organized rhythm and the conduction between the atrium and the ventricular, so that we don't see P-wave activity. There is no sinus node activity. It fires irregularly. It's conducted irregularly, and therefore it's irregularly irregular. If you see an onset of AFib with a rate less than 150, because it's usually over 150, it's either some medication side effect, one of your antiarrhythmics, consider a new onset MI or sick sinus syndrome. Those are sort of the 3 things. Most of the time you're going to see the tachyarrhythmia is over 150. The most common cause is heart failure. ischemic heart disease, and hypertensive heart disease. Gee, do you think there's anything that has a role in that? They are all common things. That's why it becomes the most common of our sustained arrhythmias. There are things we can, rule out. Is it hyperthyroidism? So we can do things like echocardiogram labs. Did they just tell you that they snorted a big line of cocaine? That may be useful with a drug screen. So the most appropriate treatment for a hemodynamically unstable A-fib would be Mays procedure, catheter ablation, synchronized cardioversion, beta blockade. Synchronized cardioversion. In general, remember ACLS, the treatment for unstable anything is electricity. So here it is, unstable synchronized cardioversion. In stable AFib, then you have to find out what's the cause, fix it if possible. So if they're hyperthyroid, get them under treatment. Then you want to slow the ventricular response. And then our debate is, do I convert them back to a normal sinus, or do I then do rate control? And finally, in both instances, I want to prevent thromboembolic phenomena. So the rate versus rhythm control, this debate has continued to rage, and really what it comes down to, there's no difference. Whether you control the rate or whether you convert them back to rhythm, there's no difference in morbidity or mortality under either option. And so sometimes rate control is a little bit easier to accomplish than rhythm control. If the other caveats are usually if the person is less than 60, rhythm control is often the better choice for them because they really do experience some of the side effects of AFib. One of them being they lose a significant amount of their ejection volume just because they've lost the atrial kick. There's no organization when that valve opens, and there's no kick to fill the rest of the ventricle. And so those patients may experience more things like fatigue, lack of energy, as opposed to somebody over 60, which tends to tolerate the rate and often doesn't notice the difference in the ejection fraction. It's just one of those things. So rate control often less than 60, rhythm control less than 60, rate often over 60. If you're going to convert them to a normal sinus rhythm, you may want to use electrical conversion, synchronized, and then with or without drug therapy. And some of the drug therapy are things like ecanamide, flecainamide, sotalol, amiodarone. The problem is, if you look at that list of drugs, they may convert your rhythm back to sinus, but they may also be pro-arrhythmic in themselves. Mostly they're the ventricular arrhythmias. The ecanamide and flecainamide, for instance, were what was studied in the CAS trial, the cardiac arrhythmia suppression trial, and they actually stopped the trial because they found they had twice the number of deaths and arrhythmias than in the control. So these do carry with it some risk, but they can be useful as an adjunct to the electrocardioversion. Again, rate control, usually 60, 65 is where we make that determination. Some people have, if you're going to do rate control, how strict the rate control? Do I need them under 100 at all times? And when you look at some of the treatment there is it's a relative rate control, somewhere between less than 110. So you don't have to have an absolute less than 100, and actually pushing that medication may actually give you the side effects. You don't want to have sustained tachycardia because we talked about that increasing the risk of congestive heart failure. And so, again, non-inferior to just have lenient rate control. If you're going to do some of the invasive therapies for AFib, not necessarily us, but our EP people, it's usually a catheter ablation around the pulmonary veins is often where the source of this rapid firing is. And these are for people, especially that have paroxysmal AFib. They're not always an AFib. They come in and they go out, but they have preserved LV function. And those are, again, techniques that continue to evolve. They should be probably done at centers that do a lot of them. I wouldn't send your patient to somebody that does 5 to 10 a year. You need to have a fairly wide range of experience. Sometimes if they're having an open heart procedure for something else, say they're having a bypass, they may be able to do a mini Mays or Mays procedure. But again, that's usually requiring us to open the chest. Now, some people, again, that have transient AFib, they can carry an antiarrhythmic, and as soon as they feel the onset of that, they take their antiarrhythmic, and that may help us. So it's the pill in the pocket approach. Again, the drugs, flecainamide, rhythmol may be useful. And who do we evaluate for thrombosis? The original studies for evaluating patients with A-fib did the study under what's called the CHADS-2 protocol. And the CHADS stands for, congestive heart failure, hypertension, age, diabetes, and whether they've had a stroke or TIA. If they've had a stroke or TIA, they got 2 points. And what you looked at is for every 100 patient years, if you had an increase of 1 point, it was a risk factor increase by 1.5. So again, showing that as you start to get above 3, the anticoagulation was probably warranted. 0, they said, not necessarily can anticoagulate and consider aspirin. If you were 1 to 2, there's an intermediate at risk, but it does average about 4% a year. And so the question was, could we refine that? And what we did was, the reason we looked at that is your adjusted stroke rate goes up as your score goes up. But that wasn't real discrimination in terms of the patients that were the 1s or the 2s. So what was created is the CHADS VASC score. And again, what they looked at was increasing risk factors, like if you were a woman, you got 1 point. If you were older as opposed to younger, you got 1 or 2 points. So you see that there's some. And then again, the other things here where it was designed to be much more discriminatory for those patients that on the CHADS-2 were just a 1 or 2, they actually showed, but those patients teased out and they were still at increased risk. So if you have A-fib and 1 risk factor, you probably want to anticoagulate. And so our goal is if it's a new onset A-fib, we'd like to prevent a clot from forming. But if you're considering cardioversion in the first couple days, you don't have to co-administer heparin. It takes time for that clot to form. If, however, this patient has had A-fib and you're not sure when, you either need to anticoagulate for probably about 3 to 4 weeks and then consider conversion, or prove that they don't have a clot with the TEE and then cardiovert. And most of the time, you're going to do some low molecular weight or unfractionated heparin as well. And so if most of the time, the problem is that the risk for thromboembolic event goes up just about the time you think you're out of the woods. And so what are the medicines we can use? Well, warfarin is our tried and true standard, but we've got all the new novel oral anticoagulants. So we have dabigatran, Rivaroxaban, known as Xarelto, Apixaban, Eliquis. And so again, they're either thrombin or factor 10A inhibitors. And so the advantage to the new novel anticoagulants is they don't require the lab monitoring. The disadvantage is price, and sometimes twice a day dosing. In patients that are easily controlled or can be relatively controlled rapidly with a good stable INR, warfarin is probably still a reasonable choice. The other reason is it's either economic or they don't want to tolerate the BID dosing of some of the medications. And the other thing is none of the novel oral anticoagulants can be useful if you have creatinine clearances less than 30. You've got to go back to warfarin because they just haven't been studied. Our INR should be between 2 and 3, and you're going to weigh this risk and harm analysis. So I'm trying to prevent the clot. I'm also trying to prevent a major bleed. Major bleed is defined as anything that needs a hospitalization, transfusion, or surgery, or that there's a major bleed in some place sensitive, like the brain. And so the other problem with warfarin, and anybody that has an EMR and has any patient on warfarin, every drug interacts. You get the interaction fatigue, right? Oh, here we go again. And so you have to worry about that. So the advantage of some of the novel oral anticoagulants is there's less drug interaction. They don't require monitoring. The disadvantage is that you have to look at some of the literature and say, well, what's that like in the real world? Because certainly these studies are well done, they're well controlled, but they may not approximate what we actually do in the office and what your patient does. If you're going to, you can combine things like anticoagulant. So you have A-fib and you're putting them on warfarin. Do I stop my aspirin or my clopidogrel because they also had coronary artery disease? And no, you can. To do that, it's okay to use the lower dose aspirin in combination with the warfarin. Some patients actually end up on triple therapy, and these are usually the people that have A-fib resulting from a mechanical valve or they've had a prior drug-eluting stent. And so the big concern here is when you do triple therapy, you have an increased risk for bleeding. Now, if you want to assess the bleeding risk, there's another mnemonic, and I love it, HAS-BLED. It's kind of cool. It's a scoring system for bleeding risk. So if you use the CHADS-VASc for thromboembolic stroke risk, you can use the HAS-BLED for whether or not they have an increased risk for bleeding, because it's not a stroke assessment tool like the CHADS-VASc is. And so it's much more useful in terms of its bleeding prediction. And again, the mnemonic is for things like hypertension, abnormal renal or liver problems, stroke, a history of prior bleed or predisposition to bleed, and again, usually things like label INR, so they've had problems with INRs, they're up, they're down, if they're older, and if they use drugs or alcohol. And drugs or alcohol, you can actually give 1 or 2 points, because if they have both, you might end up having them. And so anybody that has a score greater than 3 or higher has an increased risk for bleed. So then you have to weigh that risk and benefit. And what happens is it just helps us in sorting out those people that we know are going to be have problems with bleeding tendency. All right, so A-fib. Talk a little bit about pacemakers and bradycardia. The indications for permanent pacing are really 3rd degree or advanced 2nd degree block, symptomatic 3 seconds or more pauses, and if someone's had a prior catheter ablation of the AV node, they're usually going to need some sort of a AV sequential pacemaker. The other person is those that have neuromuscular disorders that do attack the AV node. You don't need it if they're non-symptomatic or asymptomatic, and especially if they're Mobitz type 1, or it's a temporary thing like a drug overdose. You don't really need a permanent pacer. Pacemakers are actually, if you will, labeled with a 5-letter code. And so you'll see that most of our pacemakers today are what are called DDD modes, dually sensed, dually paced, dually inhibited. So that's sort of your AV sequential. The 4th and 5th letter talk about rate modulation and tachycardia or anti-tachycardia. So that's your defibrillator type function. The issues you could get post-pacemaker, again, some of the implantation problems, pneumothorax, a pocket infection. Usually the biggest problems we have with pacemakers are failure to sense or failure to capture, and they may need adjustments. If you're looking, again, recommendations, don't do an MRI. It's not that it'll move the MRI unit, it will set it back to from a DDD to a VVI mode. It'll reset the pacemaker. Think about how we query pacemakers. They use a magnet over the phone, so the MRI will reset it. And then cellular phone, probably just move it away from the pacemaker battery to the opposite ear. There is a concern when we look at aspirin use for the patient that is increased risk for cardiovascular disease. What about concomitant use of, they say ibuprofen, but let's say non-steroidals. And so there has been some concern that if you take them together, you decrease the antiplatelet effect of your aspirin. So they probably should be separated by about 8 hours. And the other alternative is consider another analgesic that's not a non-steroidal, parentheses, acetaminophen. Finally, some stuff about syncope. Again, sort of in the cardiovascular realm. When we think of patients that have had a syncopal episode, the big dilemma is, do I admit them? Can I send them home? And this was developed as what's called the San Francisco syncope rule. It looked really good. They said, oh, it was a 98 sensitivity, 56 specificity. And so if you didn't have any of those risk factors, maybe you could send that patient home. Looked like it was ready to be published and for prime time until somebody in New York decided to replicate the study and said, wait, not so fast, the results aren't so good. So we're still left with a lot of clinical judgment on who do I admit that's had a syncopal episode, especially if it's related to a cardiovascular event. Cardiomyopathies, a whole host of things that can cause them, anywhere from infectious, drug, toxin. Remember, alcohol is a direct cardiovascular toxin, and so you can see cardiomyopathies in your patients that like to abuse alcohol. You can see it in Drug-related, cocaine example. The tachycardia mediated, you can get a cardiomyopathy, and you can get medication-induced. Typical used to be the old things like doxorubicin for chemo agents. That's why we don't use that much anymore. A lot of these also are post-viral, or we're not sure, idiopathic. And then finally, I think I'm going to get Bosman. Talk about radiation heart disease. Remember we talked about the inflammatory model, and we'll talk about that in rheumatology, but these patients that have had prior radiation treatment for things like Hodgkin's, non-Hodgkin's lymphoma, where they've had an inverse Y radiation field, these patients are showing up 10 to 20 years later with an acceleration of coronary artery disease or valvular disease or both. And it seems to mirror the radiation field. So just be aware if you have a patient or patients in your practice that have had lymphoma treatment, Hodgkin's, non-Hodgkin's, with radiation, that they may need to be screened a little bit more aggressively for coronary artery disease because we see it and it's on the rise. And I think that I am done early.